Thank you everyone. My free paper is on optimally utilizing the stenting suture for aqueous drainage devices in glaucoma. So as we all know, glaucoma drainage devices are used in refractory glaucoma, and non-wall drainage devices would function only after the ligature suture dissolves. Sometimes at dissolution there can be a precipitous IOP drop which could trigger hypotony, and delayed hypotony has also been reported with non-wall glaucoma drainage devices. So hence came the stenting suture. We use the 40-proline suture, 30-supramid has also been described. It offers continued resistance after the ligature suture dissolves. Partial removal, which I will describe in the slides to come, may be effective while retaining the benefits of the stenting suture in place. This is how the stenting suture is placed. This is the ACP250 device. So the ligature is tied over the stenting suture. Sometimes you may have exposure of the suture which may require removal, and there could be a suture track leak. So the stenting suture is buried 2 quadrants away. So this is what I mean by partial removal. Please note there is a ligature suture here. So you pull the stenting suture just past the ligature sutures. So you can see the tip of the stenting suture has come just past the ligature suture, so which is indicated by the arrow. So the ligature suture is still within the lumen of the tube. The stenting suture is still within the lumen of the tube and the ligature is in place. So this allows a partial flow through the non-wall glaucoma drainage device. So study question was, does partial or complete withdrawal reliably reduce the intraocular pressure in emergencies? Could there be any complications, and what is the optimal time for a partial removal? So could it be 3 weeks for 250 millimeter square and 4 weeks for a 350 millimeter square device? So the inclusion criteria: patients with refractory uveitic silicone oil induced neovascular glaucoma underwent GDD implantation, and an informed consent was taken from all patients, and all of them underwent a comprehensive ocular examination. So surgery was done by a single surgeon, standard technique, a patch-free aqueous drainage implantation. The ACP250, RD250 and the RD350 were used. Surgery was done under subtenance anesthesia. Venting slits were used in all patients, and the stenting suture was buried 2 quadrants away. We used the 40-proline in all our patients. Postoperative review was timed in the first day, first week, third week and fourth week, and subsequent reviews at the examiner's discretion. So standard regime was 1 week of topical antibiotic and a tapering regime of topical loteprednol. Anti-glaucoma was used for 42 days and with cycloplegic commencing from day 35. This was the routine for all patients with GDD. For those who underwent withdrawal, for partial withdrawal, which was done at 3 weeks for 250 millimeter and 4 weeks for 350 millimeter square devices. So partial withdrawal was done when the IOP was uncontrolled on maximum medical therapy with advanced glaucomatous damage, where it was believed that visual loss is imminent if some action is not taken, or when there was excruciating pain or severe corneal edema because of a raised IOP. And cycloplegics were commenced and the AGM was stopped. So complete withdrawal was done for exposure, and in 1 patient for an uncontrolled IOP at 2 months, and cycloplegics were commenced thereafter. So we had 12 patients. I mean, these were the 12 patients who underwent some kind of a withdrawal, either partial or complete withdrawal, with a mean age of 50.2 and 4.6 years, and with maximum medical therapy: 6 of neovascular glaucoma, 4 of silicone oil induced glaucoma, and 2 with refractory glaucoma, equally divided between ACP and RD250. So if you notice the figure, this is the figure taken after the stenting suture partial withdrawal. You can see the stenting suture just past the ligature sutures. So for exposures, a complete removal was done. As I mentioned, 1 patient we had done a removal because the IOP was uncontrolled at 2 months. And the first partial withdrawal that we did had an accidental removal which was done under topical. Subsequent were done under subtenance anesthesia. The rest, the IOP substantially reduced. In 1 patient it reduced only to 32 from 54, and this patient had an additional drop at 6 weeks. And this was the patient who underwent rerouting, past planar rerouting for exposure. 1 had a transient suture leak, and in partial removal the suture position was confirmed. So this was the patient who underwent rerouting along with partial suture withdrawal, and so you can see that the suture has come just past the ligature. So stenting suture does reduce the chances of hypotony. That's a known fact. An early partial removal has been described. I have included the reference here, but the literature on efficacy, the optimum timing is not there. Non-wall devices can cause IOP, delayed IOP drop, but this can be partially offset by withdrawing the suture, and possibly it is effective only prior to the maturation of the capsule, and late removal may not be of value. The other potential options that you have include laser sutural lysis of the ligature, removal of one if you have used multiple stenting sutures, and not ligating but allowing partial flow through two stenting sutures. So the implication is that partial suture removal can negate the disadvantage of a delayed IOP drop, or a two-stage implantation can be considered at 3 weeks. And the concerns, of course, small number of patients and suture tract leaks. We don't know the impact on hypertensive phase or accidental complete removal. And so intraoperative planned placement of ligature suture, strategic placement, would facilitate this maneuver. So we can try this in dire situation, and to be considered on an individual basis and not routinely for all patients. Thank you. Thank you.
Professor Kirti, can you take the...
Could you tell us how useful this information could be just from 4 cases, because 6 patients you have taken, and out of which
No, sir,
2 could not
actually,
be done a part
yes,
of study?
So in the same period of the study, we had done 25, of which 12 patients required some kind of a removal of this stenting suture. And one, it had to be removed because the suture had got exposed, which had included the photograph. In the other patient, at 2 months, the IOP was uncontrolled, so we removed it completely. There was no ligature. For the remaining 9 patients, actually, so this partial suture removal was of a very great value because the pressure was like 40 plus, and either the patient had imminent vision drop or the patient had severe excruciating pain. So we withdrew it just past the ligature suture under subtenance, because this is a very fine maneuver. If you pull it a little more, it will come out of the tube, and the very purpose of putting a stenting suture would be defeated. So we want the stenting suture inside the lumen, but we want it just past the ligature so some flow can start. So in all these 9 patients, I believe, sir, either it prevented imminent vision loss or relieved excruciating pain for these patients, because till 3 months they were on 5 AGMs and we added diamox glycerol, still the pressure was above 40. So when we partially withdrew it, we retained the advantage. None of these patients had any hypotony, these 9 patients. But in all, we prevented an imminent vision loss.
So in that patient in which you completely removed the stenting suture,
yes, ma'am.
So what was your IOP in the follow-up?
Yeah, madam. So actually, that patient, that was the first that we attempted a partial removal. We did it under topical anesthesia. So patient jerked the head and it came out of the lumen. So immediately the pressure precipitously dropped to 2. Fortunately, this patient did not have any suprachoroidal or anything, but had serous choroidal detachment, which subsided over 2 weeks, and the pressure went back to 12 or 14. But in the rest, we have done under subtenance with a traction suture in place. And in all those 9 patients, we just withdrew it past the ligature.
Why not to do walled implants in this kind of severe
sir,
cases?
the disadvantage of walled implants is that the target IOP that is achieved, because the capsule is exposed to inflammatory mediators right from the start of surgery. So the target IOP that is achieved with walled implants is more, actually. The IOP that is, it doesn't achieve the target IOP, and the success rate is less with walled implants. The other thing is walled implants are more expensive, sir. Like Ahmed Wall comes at 28,000 a piece, whereas the RD250 is only 4,000. So,
Anything?
All the 25 you said were included in this particular study?
Actually, I have presented data only for the 12. For the remaining 25, the situation was not dire. So we did not attempt any partial removal. We left the ligature to dissolve on its own. Only for the 12 out of the 25 had some kind of a withdrawal, which was almost 50%.
What exactly was the cutoff limit for the IOP for?
Yeah, sir, if it is patient with advanced glaucoma, glaucomatous damage and more than 35, or patients with excruciating pain and IOP again more than 35 was what we used as cutoff on maximum medical therapy, including diamox and glycerol.
Okay, thank you.